Welcome to the UC San Diego School of Medicine Ultrasound Series for Medical Student Education. This is the Renal Anatomy and Pathophysiology lecture. My name is Dr. Asia Takeuchi of the Department of Emergency Medicine, and I will be narrating this session. The kidneys are paired bean-shaped organs that lie at a slightly oblique angle in the retroperitoneal cavity of the abdomen, tucked just below the diaphragm and posterior to the liver and spleen respectively. They are typically located between the transverse processes of the T12 and L3 vertebrae. However, because of the location of the liver, you will usually find that the right kidney often lies somewhat more inferior in position than the left. The kidneys receive blood from paired renal arteries and drain into paired renal veins. Each kidney excretes urine into the ureter and empties into the bladder. In this transverse view, you can see that each kidney is surrounded by tough fibrous tissue called the renal capsule, which itself is surrounded by perinephric fat, renal fascia, and paranephric fat. Normal adult kidneys measure approximately 9 to 12 centimeters in length, 4 to 6 centimeters in width, and 4 centimeters in thickness. The left kidney is commonly longer than the right. However, there should be no more than 2 centimeter difference in length between the two. The parenchyma of the kidney is divided into two major structures, the outer renal cortex and the inner renal medulla. The renal cortex, measured from the outer border of the pyramid to the renal surface, is normally 10 millimeters in length. The recessed area on the concave surface of the kidney, known as the renal hilum, is where the renal artery enters the kidney and the renal vein and ureter leave. Now, let us prepare for the ultrasound evaluation of the patient. For this exam, you will want to have the machine on the abdominal or renal setting. You will want to use a lower frequency probe, either the phased array or curvilinear, depending on the habitus of your patient. For the purposes of this course, we will be using the phased array probe. The patient should be placed in the supine or lateral decubitus position with his or her ipsilateral arm raised above the head. You may also find that having the patient take a deep breath in or out may help move the kidney into a better view. As always, be sure to explain the process to the patient before you begin. Some clinical indications for this type of exam are flank pain, hematuria, renal failure, evaluation of possible congenital, pathologic, or infectious abnormalities, follow-up of post-surgical complications, guidance for aspiration or biopsy, and screening for injury in the setting of trauma. You should also be aware of the limitations of the study. Mainly, the mid to distal ureter is generally obscured by bowel gas, and small lesions at the upper pole of the kidney may be difficult to see due to refractive edge shadowing. Let us start our exam on the right. Your approach for this side will be to place the probe in the right lower intercostal space in the mid-axillary line. Using the liver as your acoustic window, aim the probe slightly posteriorly. For the long axis view, you will start with the marker dot pointed towards the patient's head and then fan anterior to posterior, or belly to back. To switch to the transverse view, you will rotate 90 degrees from the long axis and then fan from the superior to inferior pole of the kidney, or head to toe. Placing the probe as instructed on the prior slide, this will be the position on the patient. To minimize rib shadow, it may be necessary to rotate the probe to a slightly oblique position to account for the oblique lie of the kidney. Fanning anterior to posterior will give you a complete longitudinal evaluation of the organ. As you can see, the outer cortex of the kidney is somewhat hypoechoic when compared to the liver. Moving deeper, you will see the triangular pyramids that are even more hypoechoic than the cortex, or may even appear anechoic. At the center of the kidney is the renal pelvis, which appears as bright hyperechoic space, brighter because of the increased amount of fat in that area. We will now switch to the short axis and be sure to fan from the superior to inferior pole of the kidney. Be aware that when scanning through the kidney, if you see a well-circumscribed, particularly bright area with posterior shadowing within the renal pelvis, you may be looking at a kidney stone. In this video, the stone appears within the green circle. Renal parenchymal stones are not the lesions that are responsible for patients becoming symptomatic, but it is rather when these stones dislodge, enter the collecting system, and become trapped that they cause the patient pain. Also in this slide, you will see an example of perinephric fat. You will find this deep to the red arrow. Notice that perinephric fat is hyperechoic and should not be confused for free fluid, which would appear anechoic. We will now move our exam to the left. For this side, you will place the probe in the lower intercostal space on the posterior axillary line, more cephalad and posterior than when visualizing the right kidney. This is how your exam will appear on the left side of the body. As mentioned before, the probe will be in a more cephalad and posterior position. You may need to adjust your probe to a more oblique position to avoid rib shadow and get a better exam of the organ. As before, we will start with the marker dot towards the patient's head, fanning from the anterior to posterior view in the longitudinal axis to the short axis, and fan superior to inferior, completing our exam of the left kidney. This is an example of hydronephrosis. An obstructive process distal to the kidney has prevented urine from draining distally. This backup causes dilation of the renal pelvis, which will now appear as a largely anechoic space at the center of the kidney. Consequently, the renal parenchyma, the more hyperechoic perimeter of the kidney, becomes compressed. The renal arteries run retroperitoneally from the aorta to the renal hyla. They lie deep from an anterior approach and are often partially obscured by the bowel, making them difficult to see well. However, when visualized, spectral waveform may be used to assess the peak velocity and resistance index to search for evidence of renal pathology, such as renal artery stenosis or acute tubular necrosis. The ureters are narrow muscular tubes, typically 4 to 6 millimeters in diameter. However, the lumen can stretch from 2 to 8 millimeters depending on peristalsis. They start at the pelvic ureteral junction and run a retroperitoneal course, typically just lateral to the tips of the spinal transverse processes. They then cross the iliac artery and veins anteriorly, and at the mid-pelvic level turn medially to enter the bladder. Do you remember the kidney stone that we saw earlier in the lecture? It has since moved into the ureter and is likely causing the patient a fair amount of pain. Recall, one of the limitations of renal ultrasound is that the mid to distal ureter is generally obscured by bowel gas, making them difficult to see. However, in the setting of an obstructive uropathy, such as a large ureteral stone or prostatic hypertrophy, the ureters may become dilated and thus more obvious on ultrasound. This is a finding we call hydroureter. The hollow muscular and distendable organ, the bladder, sits on the pelvic floor. Urine enters the bladder via the ureters and exits via the urethra. Some of the indications for ultrasonography of the urinary bladder include assessing the vesiculo-ureteral junctions and bladder emptying in cases of suspected obstruction, looking for tumors, calculi, foreign body, or diverticulum, and using the full bladder as an acoustic window to assess the prostate in males and gynecologic structures in females. Limitations to consider are extensive pelvic scarring or overlying bowel gas that may make scanning the bladder difficult. Also, if the bladder is not sufficiently distended, pathology may be hidden by the folds. As with the kidneys, you will want to evaluate the bladder in two axes. First, the sagittal view, depicted by the picture on the left of the screen. Then you will rotate the probe 90 degrees to obtain the transverse view, with the anatomy appearing as illustrated on the right side of the screen. To obtain the sagittal view of the bladder, start over the pubic symphysis with the marker dot pointed toward the patient's head and the probe angled inferiorly into the pelvis. The bladder will appear as an anechoic structure at the top of the screen. Deep to it, and sometimes superior to it, you will see the more hyperechoic uterus. As always, you will want to fan through the entirety of the bladder from side to side in this view. We will now switch to the transverse view by moving the marker dot to the patient's right. The bladder will appear as a hyperechoic structure at the superficial portion of the screen with the hyperechoic uterus just underneath. As always, you will want to fan through the entirety of the structure from the superior to inferior portion of the organ. Similar to the illustrations of the female bladder we looked at, these are renderings of the male anatomy in both the sagittal view on the left of the screen and the transverse view on the right. Depending on the level of the probe in the transverse view, you may see the seminal vesicles or prostate deep to the bladder. Make sure to scan all the way through the bladder to try to find both. This video shows an example of prostatic hypertrophy. The prostate is so enlarged it appears to be sitting within the bladder itself. Do you remember the example of the kidney stone we looked at earlier? Well, this stone has migrated into the bladder. Now on to bladder volume. You should look to measure the bladder volume pre and post micturition. As a rule of thumb, the bladder should empty to approximately 10% of the pre-micturition volume. Most machines will have a bladder volume calculation tool. Once you input the three-dimensional measurements, the machine will calculate the volume for you. In order to obtain these three measurements, you will need to use both the transverse and sagittal views of the bladder. This should be very similar to the approach you used in the last session to evaluate the volume of the thyroid. Starting in the transverse view, freeze the image and measure both the AP and lateral diameters. You will then need to unfreeze the image and rotate your marker dot towards the patient's head to obtain the sagittal view. In this view, you will measure the third craniocaudal dimension. A volume of less than 50 milliliters is normal. Less than 100 milliliters is usually acceptable in patients greater than 65, but abnormal in younger patients. Lastly, let us look for ureteric jets at the bladder base. This confirms bilateral renal function and ureteric patency. To do this, you will want to be in the transverse view with the probe angled inferiorly. You will need to be patient while waiting for the ureteric jets depending on renal function and degree of hydration. Jets of urine passing from the ureters into the bladder can be seen on grayscale ultrasound in the upper right portion of the screen. The jets appear to be slightly more echogenic than the rest of the urine in the bladder. The reason for this difference in echogenicity is not fully understood. In the bottom left-hand corner of the screen, you can see the ureteric jets on color flow. They point obliquely to the opposite side of the bladder and occur intermittently, often several minutes apart. The presence of a jet excludes complete but not incomplete obstruction. The absence of a jet suggests but does not prove obstruction. This concludes our lecture. I thank you for your time. Have fun scanning!